Good morning. Good morning, everyone. My name is Jeff Pittman. I'm the Chancellor of St. Louis Community College, and on behalf of the trustees, faculty, and staff and students, I'm pleased to welcome you to our 16th annual State of the St. Louis Workforce Report event. And can't believe this is my 10th one, but this report continues to grow in popularity. When you look at, if some of you may have noticed, we've got a couple of new buildings going up on this campus. We're actually building 6 across the district. All of these buildings are linked to workforce sectors like healthcare, IT, advanced manufacturing, financial services, biotechnology, all of those high-need sectors that we have. The workforce report actually helped drive us to the planning that we had in the buildings that you're seeing going up right now. We have a lot of other things that the college is doing as well to better serve the community and better serve our employers. We've been striving to keep our costs down. In fact, we haven't raised tuition now for 4 years. We want to provide a very affordable option for our students. And we're moving toward a guided pathways model where the college is organizing itself around programming that aligns with high-need employment sectors here in the region. Well, I just want to start out by thanking our workforce partners, including the Missouri Economic Research and Information Center, who produced the economic data in our report, and MoSource Link, who provided the data on startups and new job creation. I also want to thank the Missouri Chamber of Commerce and Industry, the Federal Reserve Bank of St. Louis, and the Regional Business Council for their ongoing support and their partnership. And then I would not want to miss out on an opportunity to introduce at least one of, I know we have one of our trustees here, Mr. Rod G. Rod, could you stand and wave to everybody? Did I miss any other trustees? You might come in and I missed. And then we have a trustee emeritus, Joan McGivney. Joan, do you want to stand up and be waved? Joan was trustee at the college, one of the trustees that actually hired me. So thank you, Joan. It's been 10 years. It's been wonderful. Finally, I'd like to introduce one of our longest and closest partners in this effort, the St. Louis Business Journal, led by market president and publisher Robert Bobroff. Robert, could you come up, please? Give him a round of applause.
Thank you, Dr. Pittman. Good morning, everyone. St. Louis Business Journal is proud to once again be partnering with the St. Louis Community College on this annual workforce event that is so important to our community. This has always been one of my favorite events of the year because workforce is the backbone of business, and it's a topic that's near and dear to our heart at the Business Journal. And as a testament to that, I'd like to point out and introduce our reporter on workforce development, Jim Drew. Jim, wave. Welcome. Thanks for coming today. Earlier this year, on March 29th, to be precise, the St. Louis Business Journal published its annual Workforce Development Guide. We partnered with St. Louis Community College on that project as well. We don't produce many dedicated guides each year at the Business Journal, and so it's a testament to the importance of workforce development to our business community. That guide was so successful that now close to 20 of our sister publications across the United States now produce their own annual guide. St. Louis Community College should be commended for their continued efforts to move our region forward around this topic. If you are a subscriber to the Business Journal, which you all should be, this Friday you'll see we have a special cover wrap around the Business Journal. It'll have a lot of great information around the report that you're going to hear about today. So Dr. Pittman, thank you again for giving us an opportunity to partner with you and be a part of today's program. And with that being said, now please join me in welcoming to the stage Phyllis Ellison, Associate Vice Chancellor, Workforce Solutions Group, to present this year's report. Thank you.
Good morning. It's great to see so many people out, both in the summer and after the last 2 years. It's wonderful to see a much fuller house than what we've been able to have with the pandemic. So good morning, and we're so excited to present this year's numbers. I'm a bit of an econ geek at heart, so I really get excited when we have the numbers and to look at the progress that our workforce is making here in the region. We have a great lineup for this morning. I'll be presenting the highlights from the report today. And again, these are highlights, not the whole report. We also have a panel on AI in healthcare, and then a speaker on AI in healthcare, and then we have a panel discussion on workforce trends in healthcare as well. There's 4 parts to the report and 4 parts to the presentation that we'll cover this morning: the St. Louis economy, an employer survey that is representative of the employers across the region, and getting their thoughts and ideas related to their workforce. Also, the spotlight on startups and the spotlight on healthcare. We'll start with the St. Louis economy. This really sets the backdrop for all the other discussions around workforce, because you need to understand unemployment rates, all of those things, to see where the impacts that we're having on the workforce and things we need to pay attention to. First, First, we want to celebrate this number. Hopefully you've seen it in the news lately. We have a brand new largest size of the workforce here in the St. Louis metropolitan statistical area, 1,495,200 workers. This is the largest our workforce has ever been in the region. And additionally, this puts us in top 10 in cities in the nation in terms of our workforce growth. It's really nice to be in a top 10 list talking about growth for a change. So we're very excited to see these, this sort of growth, and these are really recent numbers. Let's talk about the unemployment rates. Over the last year, we were seeing unemployment rates here in the St. Louis region between 3.2 and 3.7%. July numbers here most recently, we were up to about 4.3%. But it's still a tight labor market, and employers are still struggling to find workers with the skills that they need. This slide also puts perspective on the fact that the St. Louis unemployment rate tends to run lower than the national unemployment rate, and we're right around the same rate that Missouri runs. It really depends on month to month. On this slide, this looks at the educational attainment of our workforce in the region. Educational attainment of 1.5 million people. If you look at the 2 sets of bars on the right of the chart, that shows a bachelor's degree or higher, and that's 39% of our workforce. If you look at the 2 sets of bars on the left, that would be a high school diploma or less. That's 32% of our workforce. And then in the middle, you've got the remaining 30%, and that would be some college education, perhaps an associate's degree, but not a full bachelor's degree. It means we have a lot of people in the region that have capacity to take on training, to take on education. 32% of 1.5 million people is 480,000 people. I know Dr. Pittman would love to see that kind of enrollment. But truly, it gives us a great opportunity to recognize that we have so many workers in our region that could be adding skills and filling needs that we have in our workforce. This is one of our favorite charts, and it really shows the connection between education and what kind of lifetime earnings, median earnings that a worker can have. And it's a direct correlation. The more education a worker has, the higher their median wages. And of course, you look at that over a lifetime, and you really start to see significant growth and opportunity for wealth creation for that person. The flip side of that is that unemployment goes down with the more education that you have. So this should really be our goal. It's not everyone that needs a bachelor's degree, but everyone could pick up some skills. And even moving from a high school diploma to having some college or an associate's degree increases annual median wages by 23%. I think everybody would love to have a 23% raise. If you go from a high school diploma to a bachelor's degree, you're looking at a 100% increase in median wages. It's an interesting time right now because the discussion happens constantly around, is a four-year degree worth it? Should we be encouraging students to do this? Can't say that there's a right answer for everyone, but I think the question is less about should we be having education and more about the value behind the education. I agree, it doesn't make sense to saddle students with tens of thousands of dollars of debt, or in some cases, hundreds of thousands of dollars of debt. So finding the right training and education that provides true value and still allows that worker to have those increases in pay is probably the right path for a lot of individuals. When we break down that unemployment rate by gender and by age, we see a very different picture. It's not 4.3% or 3.7% across the board. Once you get workers to the age of 30 and older, unemployment rates are pretty consistent between men and women, and they're pretty consistent over time. Get from age 29 and under, however, and you see a very different picture. 7% unemployment for women, 10% unemployment for men. If we started to dice this by further demographics of race, you start to see a very different picture as well. And what it really, really drives home is that our youngest workers, we need to be exposing them to the opportunities they can have in different industries, as well as helping them get into training. In today's workforce, 44% of the bachelor's degrees, 44% of women have bachelor's degrees. 35% of men have bachelor's degrees. And this goes back to the 1970s when we started to see a flip of more women going to college than men. We need to be encouraging the training. We need to help people understand the path that they can take to get to the career that will see them through their lifetime. Our region is really fortunate when we look at the industries that we have a very diversified economy. There are some cities, I'll pick on Detroit, you think automotive. Here in St. Louis, we have 10 industries that employ 80% of our workforce. There's a lot of different opportunities for people to shift between industries, and also there's enough depth in most of these that people could move within an industry to multiple employers. The top 5 industries here employ about 54% of our workforce in the region. So you start to see that people are very concentrated in some areas. Again, we're fortunate that we have 10 that have significant presence here. 9 of the 10 have grown over the last decade, which is also great. We don't see, especially with the pandemic in the middle of this, we're not seeing one of these areas in decline. Healthcare increased by 14%. The size of the workforce increased by 14%. Manufacturing workforce increased by 9%. Professional, scientific, and technical services, that's where a lot of our startups come from, increased by 22%. And construction workforce increased by 21%. And transportation and warehousing up by 25%. Which if you think about how much we all order online these days, that makes a lot of sense. Next, we're going to move into our employer survey. Each year, so for 16 years, we've been asking employers in the region a series of questions. This is a pretty detailed survey. It's 20 minutes of phone conversation. This is not a quick click of a couple buttons and you're done. So we appreciate all the employers in the region that took time to do this. We have over 600 companies that participated, and they are representative of the companies in our region by industry, by size, and by geography. We've asked pretty much the same set of questions for 16 years, and we also had some new questions each year to look at trends, and we'll hit on a couple of those. We always ask our employers about their hiring practices over the last year. Nearly 30% of the companies hired workers last year, 15% cut employees, and we have a big group in the middle, 57%, that stayed steady. This is pretty similar to last year's numbers as well. We also asked them to forecast their hiring for the next year. This is always interesting because there's a trend here. Hiring magically jumps to 45%, 43% over the next 12 months. The number that expect their workforce to stay the same is about the same at 54%. And then there's only 3% that plan to cut employees. What we see every year is that the forecast is way more optimistic than reality when it gets reported the next year. So we'll look at this next year, but we tend to see companies being much more optimistic and very few reporting that they will decrease their workforce. But the reality is the next year is probably a little bit less hiring and a few more that choose to cut employees. Each year we ask our employers as well about barriers to growth. What's getting in the way of them growing their company? Having a shortage of workers with the knowledge or skills that are needed is the #1 answer, and that's been that way for almost 10 years. So it's really an interesting viewpoint. It shows how critical our workers are. If it's getting in the way of companies growing, companies don't grow, our community doesn't grow. The second 2 items, the economic conditions and the government policies and regulations, are up a little bit this year. Last year, they took a big jump less, which is great. So really to see them drop was a surprise. And this year, I'm surprised that they're not up even further than is showing here. Particularly economic conditions. With the interest rates where they are, it's a concern for a lot of companies. I would have expected economic conditions to have been a bigger concern for companies, but it's great that companies are not seeming that concerned, and hopefully it bodes well for continued growth. The last 2 items on this slide, a lack of access to transportation and a lack of childcare access, disappointingly, are about the same percentage every year. You've got 5 different years represented here that go back to 2013. And I show these every year because it means we haven't really driven the agenda on fixing these 2 problems. And it's something that is not going to help our workforce any if they can't get access to childcare and they can't get to their job. Excuse me. Each year we ask the employers as well what they're doing to address these shortages of skills that they're seeing. Most are still reporting that they're forced to hire workers that don't have the skills that they want and then training them once they arrive. And most of that training is on-the-job training these days. Second one is offering additional wages. Over the last several years, we've all seen kind of the hiring frenzy, and that workers were reporting getting significant raises when they were changing companies. What we're hearing through research and also reports from employers is that is starting to wane. Yes, there may be some increase in pay if they're changing companies, but it's not the hiring frenzy and the big increases that we were seeing over the last couple of years. We also look at the workforce in the functional areas, so not just as one large group, but when we start breaking it down into industries and the type of work that people do, we also see a very different picture. In this case, skilled trades, patient care, and manufacturing and maintenance have very different needs and shortages as compared to the other industries that are on this slide. And we break this down even further, and we look at those needs in 3 different categories: high skill, middle skill, and low skill. High skill would be a bachelor's degree or above. Middle skill would require some training and education, but less than a bachelor's degree. And low skill would be work that would require a high school diploma or less. And when we look at these same functional areas by skill need, we see a very different picture again. 2 of the industries have a much bigger need for the high skills, accounting and IT. Low skills are needed in manufacturing and customer service. And then what you see across the middle is an area that we really need to be focusing in, and that's where can we provide skills and training, less than a bachelor's degree, that can move people into jobs that are needed badly right now. Every single one of these categories has a need for middle skills of 40% or more, and most of them have a need of 50% or more. So it's an area that we really can be making great strides in. We asked the question for our employers about where they source their talent. Are they just throwing up ads on Indeed, or are they having to pursue and look a little harder? And I think we all know over the last several years, every employer has been looking a little bit harder. Last year, we saw a significant change in the responses for this question. Up until last year, four-year colleges were the primary partner of choice for companies to go to source their talent. That was number one. You can see it's number 4 here, and that's where it switched last year. Nonprofit organizations, many of whom are in this room today, that are supporting workers, helping them find jobs, getting them prepared for jobs, moved into that number 1 slot. And this year we saw training institutions jump with a 7% increase in responses from employers, moving into the number 2 slot. Interestingly, the next 3 categories, the K through 12 districts, 4-year colleges, and 2-year colleges, the percentage of response from employers hasn't changed. It's only varied by about 1%. But the focus has really been for employers to find some additional sources in those nonprofit organizations and the training institutions. Last year, we introduced a new question around remote work. I think it's probably one of the more fascinating conversations, and I don't know that there's a company where it isn't a top conversation in HR and other parts of the company. 3 years ago, 60% of our employers were reporting that workers were remote. This year, the results really surprised me. 86% of the companies in the survey reported that their workers were on site full-time. Not at home one day, they were on site full-time. I did not expect a number that high. 11% of the employers are reporting that their workers are in some days, so they may be home from working remotely 1 to 4 days a week. Only 3% were reporting that their workers are fully remote. Again, I didn't expect this kind of a swing back to workers being in the office, but it's certainly been a big shift from what we would have expected a couple of years ago. For perspective, in 2019, the estimate is that 6% of the workforce nationally worked remote at all, not full-time. And so it's obviously a big adjustment to today, but I didn't expect this much of a shift back into the office. We also asked employers what their plans were for the next year. Are they expecting to change their remote work policy? 87% are not expecting to change, and only 13% are expecting to make an increase or a decrease. A new question that we added this year was around training. We asked a couple different questions, but I think this was the most interesting response. For the most part, employers felt that their employees, their workers, are interested in training. Some wanted more training than was even offered. This is interesting to me. Of the 600 companies that responded, 24% do not spend any money on training their workers. If that is really representative of our region, I'm concerned. It's a concern for our workers growing in their existing jobs. It's a concern for companies retaining workers, because if they're not growing, they're going to have to go someplace else to do that. Additionally, we have another 42% of the companies in the survey that reported spending $500 or less per employee per year on training. $500 doesn't go really far in training these days. So again, I think when we're looking at really growing employees and retaining employees within a company, this is something that has to be looked at structurally. I think there's another disconnect here. Traditionally, as a society, we have expected workers to go get trained and then go find a job. In this case, I think that's what employers are waiting for. They're waiting for people that are skilled and trained to come find a job. But when we look at the workforce nationally, depending on which reports you look at, over 60% of the workers in our country live paycheck to paycheck. And that's at all demographics, all socioeconomic levels. Additionally, another 30% of workers have less than $1,000 in savings. That means that our workers can't afford to step away from their job, miss paychecks, go do training, and then go find their new job. And so we've got a big disconnect here. If employers are not interested in training or don't have the funds to train, and then additionally workers don't have the funds to train, we're going to have to figure out how to bridge that gap. Another question we asked was around skills-based hiring. This is a national discussion, skills-based hiring as compared to hiring for degrees. And a lot of conversation going on. It's an interesting response. 24% of our companies in the survey have already made that adjustment and are doing skills-based hiring. Another 12% are in the process of doing that. That also means that 64% are not. And companies in our region may be missing out on opportunities to hire skilled workers because they have the skills, but not degrees, and the algorithms and the hiring systems are ruling them out. Next, we're going to talk about startups in the region. Some of you know me. I've spent about 15 years working in the startup industry before coming to St. Louis Community College. This is near and dear to my heart. The information we're going to share today is new. It's unique to the region. This is data that we are bringing in because we did not have the perspective on how many startups and how many jobs were coming out of our startups. Last year, we had over 11,000 brand new first-time jobs created by startups in the region. This is a really unique picture. This is not existing companies adding new jobs. These are brand new startups and the jobs they create in their first years. It's a pretty narrow look. It also doesn't include if you're a small company, if you're a startup, but you're a solo entrepreneur, you don't get counted here. If you're using contractors, it doesn't get counted here. This is truly just looking at brand new full-time jobs. When we look at the trend over time, so we have 9 years of data here. The great news is we had 11,000 new jobs. The bad news is it's the lowest rate of new jobs out of startups that we've had in 9 years. The number of startups is down as well. But you see over time, if you add up those 9 years, it's over 130,000 new first-time jobs that have been added to the region by startups and small businesses that started here over the last 9 years. It's been a rough couple years, though. We have a mix here in terms of the types of businesses. Both are high-growth, high-tech companies, as well as traditional small businesses. Venture capital has been down over the last couple years, so our startups in the region that are aiming to be high-growth don't have access to as much funding. And additionally, locally, the accelerators in our region, a lot of them have wrapped up their funds, and we have far fewer choices for our startups to get that first $25,000 or $50,000 of equity investment than what they would have had 4 or 5 years ago. And then for our traditional small businesses, most of them are funded through loans and debt. And obviously right now with higher interest rates, that may create just enough of an expense that a company can't get started and get off the ground. Then intriguingly, a strong job market actually means fewer startups. If you can get a really great job, benefits, steady paycheck, strong workers are inclined to take those jobs rather than take the risk of starting a business. So in times of low unemployment, we tend to see fewer startups as well. When we look at the industries here that are represented, it makes total sense. Healthcare is the largest industry in the region, also has the largest number of jobs created by startups, over 43,000 jobs in the last 9 years. I'm going to do a quick deviation here. As you leave today, Robert referenced this, you will actually get a copy of the Business Journal wrap. And on the back of it, there's a wonderful QR code with a survey for small businesses. If you're an entrepreneur, a small business owner, we would love your thoughts. And this is something we're doing in partnership with other startup organizations in the region. This information will be shared so we can help identify what needs our startups have in the region, so we can start to fill in those gaps. So please take a moment, share that information with someone you might know, and we'd love to get their thoughts in the survey. Finally, we're going to talk about our spotlight on healthcare. So we mentioned the healthcare industry is our largest employer in the region, with over 221,000 jobs. Last year alone, the healthcare sector added over 4,000 jobs. And when you look back over the last decade, there's been a 14% increase in the number of jobs in healthcare, as well as healthcare represents about 14.8% of the jobs in the region. When we look across the St. Louis MSA and the state of Missouri, healthcare accounts for 9% of the GDP, the gross domestic product. So it's a major driver of our economy as well. Finally, I want to mention the four sectors that, from an economic standpoint, make up healthcare. 3 of the 4 sectors saw significant growth over the last decade. Nursing and residential care was the only one that didn't, and it fell by excuse me, 12%. The others all increased between 12 and 34%, so significant growth there. We all know that healthcare has taken a really rough time during the pandemic. Turnover rates were high, burnout was high, and so addressing the needs to continue training to replace those workers, as well as most of our industries are facing an aging workforce. And so looking ahead over the next 5 to 10 years, you're looking at an additional need to replace workers. I feel really fortunate that, especially our major hospital systems here in the region, Mercy, BJC, SSM, have all taken really creative approaches to hiring workers. From entry-level healthcare workers through nurses, they have created programs that pay workers while they're going through training. And this may be months and months of training. And I think, as we mentioned earlier, that disconnect of a worker can't step away from a paycheck, even if they know that if they go through training, they can get to a better job and a better career path. The hospitals have taken an approach to this, and rather spending money on recruiting, they're spending money on hiring workers, training them, and creating the workforce that they need. So I think they've really created some interesting models that hopefully other industries here in the region will be able to learn from as well. That is the report. You will be able to, by the time you get back to your office this afternoon, you'll have an email with a link to download the full report. These are the highlights. There's another 45 pages that you can explore and read. As I mentioned, you'll have a copy of the wrap from the Business Journal on your way out, and also please look for the Business Journal on Friday, because as Robert said, I'm sure everyone gets the Business Journal. So please make sure you watch for that as well. We're thrilled to have our partners that have worked with us, SourceLink, Merrick, the state, the Federal Reserve, Probalski Research. We appreciate their contributions significantly. I'd also like to extend a thank you to my staff and the team here at Merrimack, the Merrimack campus, for a fabulous job of putting things together today. So I want to thank them. As we were looking at healthcare as the trend industry for this event, the one thing that came up in almost every conversation was artificial intelligence. What is AI going to do to the jobs and the workforce of healthcare? And recently I was fortunate to meet Dr. Philip Payne at Washington University, and he is our next speaker with a fabulous presentation around the impact for AI on healthcare, and I present to you Dr. Philip Payne.
I was going to make a horrible joke and say I'm now going to cover the next 45 pages of the report with you. Luckily, that is not what I'm going to do. So I really appreciate the invitation and the opportunity to be here. And what I want to do is talk a little bit about the role of artificial intelligence in terms of driving quality, safety, outcomes, and value in healthcare, and how that also represents a growth opportunity for our region. And I hope by the time I get done, I will get you excited about what's coming next in terms of AI across not only our health systems, but really all sectors of our economy, because the reality is that healthcare touches all sectors of our economy, because without a healthy, high-performing workforce, it's very hard to achieve the types of growth that we just heard about. And I did start out with a quote from one of my colleagues at Stanford University who leads a Center for Human-Computer Interaction and AI, and I really like this because the reality is that as exciting as the current state of the art is in terms of artificial intelligence, we are still really looking at just the tip of the iceberg. So what I'm going to talk to you about today is really a starting point and not sort of the culmination of the opportunities around AI. So I'll start by saying it is incredibly hard to not read, hear, or otherwise be made aware of the incredible growth happening around artificial intelligence. This is happening not only in the scientific and technical literature, but in general everyday conversations. And you are probably using artificial intelligence on a daily basis, sometimes without even realizing it. It's being baked into the mobile devices that you have in your pockets. It's in the devices that help you at home, for example, maybe a voice assistant that you might use. It's in your cars. It's in your word processor that you might use. It's in your favorite email client. And in a lot of ways, AI is being embedded in ways that we are sort of only beginning to realize, and therefore awareness of AI is really important. And then, of course, in the scientific side of the equation, there is incredible growth in terms of our understanding of artificial intelligence and how we can optimize its use in all of these different settings. So it would be almost impossible to talk about AI in healthcare and not use at least one infographic from our friends at Gartner. I actually think there might be a legal requirement that I use at least one Gartner hype cycle slide. But I do think it is important to recognize when we talk about this that we are without a doubt at the top of that sort of peak of inflated expectations for artificial intelligence. This is a natural process with new technologies. We see it time and time again. And the real question is, how do we navigate the inevitable decline in enthusiasm as we sort of get to the pragmatic stage of deploying and using these technologies, and ideally arrive at sort of what Gartner describes the plateau of productivity, right? This is where we move beyond hype and we actually see impact. And I would argue, and I'm going to make this argument multiple times in this talk, that we in St. Louis, in this region, are ideally positioned to drive the innovation and applied agenda that will get us through this hype cycle. In fact, I would argue we are a better place to do this work than many of the places that people regularly think about, say our colleagues on the coasts. So, some people, and I would certainly say that I'm an AI optimist, and I would use this turn of phrase, describe the advent of modern artificial intelligence as really a fourth industrial revolution. And I'm not going to spend the rest of today talking about the prior three industrial revolutions, but they have to do with things like the availability of automation, more ready access to power supplies, all of the things that have led to sort of increased productivity in the human workforce and in economic development. And so today, we are moving from a stage where we think about automation as the way to optimize our economy and productivity to one where intelligence, where we take high friction, low value tasks out of everyday life so humans can focus on the things that humans are uniquely good at, is going to be what drives growth. And that is the fundamental of artificial intelligence. Artificial intelligence tools are not particularly smart. And I know that there's conversations around, are these tools like ChatGPT sentient? They are not. In fact, what they do is process information faster and at a greater scale than our human brains can process it. But they are not intrinsically intelligent. So this next stage of growth is really about how do we leverage human intelligence together with computers to drive productivity. So we mentioned in the workforce report that training was an important part of developing our local economy. So this is my investment in training. Everyone will be able to walk out of this room and declare themselves an expert in artificial intelligence. Because as complex as the topic may seem, it's actually not that complicated to build an AI tool. It always starts with data that represents some sort of problem domain. And then we're going to build a model, something that replicates expert human decision-making based upon that data. All we're trying to do is get that knowledge that humans use to solve problems and encode it in a way that computers can use it. And then we deploy that model, and as I talked about earlier, the scale and speed of computers is intrinsically greater than that of the human brain, and therefore we get greater performance, and then importantly, we monitor and optimize. And this is a dynamic process. There is no situation where you say, I've built an AI tool and it is done. I get this question all the time from the people that I work from. When will you be done with this AI project? And I usually laugh and tell them I'll never be done, because it is a process that is continuously being refined. But at the end of the day, whether we are building predictive models or we're using now large language models like ChatGPT or whatever comes next, this fundamental life cycle is how we build artificial intelligence tools today. We acquire data, we build a model that replicates expert human decision-making, we apply it, we learn how it operates, we improve, and we repeat. Now, as I mentioned, large language models are a popular topic, and again, much like the hype cycle slide would be probably in jeopardy if I didn't talk about them briefly. You've probably all used one of these large language models. In fact, I won't embarrass people, but I bet everyone here has used one to write an email or a letter or a paper or something like that. You're shaking your head. You're the one person in the audience that hasn't used it. We'll talk later. Trust me, I use it for that purpose. But the bottom line is, what these large language models are doing, back to that sort of life cycle I talked about before, is they're ingesting all of this written human language. And they're looking at the patterns in that language. Given some set of input, a question or a prompt, what are the most likely words to follow that will answer that prompt? And one of the things I want to point out is that it is predicting what you want it to say. It does not understand what it is saying. Those words are just a function of probability. It's incredible what can be predicted based upon learning on sort of all of the written language that's in the public internet or otherwise. But the reality is that large language models are simply a predictive model that takes all of that written language and predicts, given a prompt, what it thinks you want as the output. So this is really important when you think about certain, as I mentioned earlier, high friction tasks where we might produce human language, but it actually requires a lot of effort and the value proposition is low. And that's where we're seeing a lot of the applications of large language models. In healthcare, there are still opportunities to improve upon this, and I'll talk more about this in a moment. Today, we can get results, such as the ability to extract critical information from electronic health records using large language models that are better than the prior 2 to 3 decades of natural language processing research. And that's with general purpose large language models that have basically been trained on the contents of the public internet, Wikipedia. Imagine what it will look like when we train these models on specific, highly curated knowledge bases. And that's what's coming next, and that's actually what I'm alluding to on the bottom part of this slide. And we already see technologies such as Google's Gemini that are designed to run on your phone or your local computer. They won't require the types of high-performance computing infrastructure that ChatGPT is using today. So again, I mentioned at the beginning, we are looking at just the tip of the iceberg of these technologies. And that comes back to sort of this, and I can't help myself because I'm a professor, theoretical construct, which I want you all to walk out of this room thinking about. AI is not about replacing humans. AI is about improving what humans can do. We intrinsically have cognitive strengths around reasoning upon fuzzy and incomplete information. And computers still are not good at that. Remember my life cycle for AI. We have to have that data and we have to learn those patterns. But what if the data is incomplete or the patterns are incomplete? Humans are very good at this. I'll give you a concrete example. That's a table in the middle of the stage. You don't have an encyclopedic knowledge of what every table in the world looks like. You have patterns that you use, that a table has a top and legs, and if I set something on it, it won't fall off. And you, in real time, apply that pattern to what your visual input system perceives and decide that that's a table. There's incomplete information. Maybe it doesn't quite look like a table you've seen before, but it's a pretty high probability you'll figure that out. Computers still are dumb, literal machines. So if you don't have that pattern encoded, or you can't learn that pattern from the data, you won't know that that's a table. So that's why AI working in conjunction with humans is so powerful, because the AI can learn from humans and improve its performance, and likewise, AI can filter a lot of extraneous information and help humans to focus on those pattern recognition tasks that we are uniquely suited to undertake. The human brain is optimized to remember and reason on 7 plus or minus 2 pieces of information at any point in time. That's actually why phone numbers are the length that they are. So the reality is that in the world that we live in, we are confronted regularly with thousands, tens of thousands, hundreds of thousands of pieces of information. The human brain cannot process that. So again, AI working together with humans allows us to filter and make sense of all that input and allow humans to get down to those fundamental pattern recognition tasks. So if you put that all together, and I think it speaks to the type of transformation that we're seeing in our economy and the opportunities certainly in healthcare, this is sort of a precipice of what I would describe as a true digital transformation of healthcare. Many people would argue that the advent of electronic health records was the transformation of healthcare, but it's not. Because electronic health records literally took exactly the workflows that we did on paper and put them in the computer. It did not change the way we deliver care. It certainly made that information perhaps a bit more accessible, but we didn't fundamentally re-engineer healthcare. AI as a tool to help patients, clinicians, caregivers, community members to reason on increasing amounts of data that we might get from genomics, imaging, social determinants, not to mention electronic health records or sensing, that is an opportunity to fundamentally reshape how we deliver healthcare. But that does lead to 4 really important questions that we have to ask every single time that we're going to use artificial intelligence to improve healthcare. And there's nothing surprising here. The first question is, when we're trying to automate something using AI, we're trying to achieve that 4th industrial revolution, is the task even suited to what we are trying to do? Is it the right type of problem? Then, do we have that data? Is it accessible today in a computable format? And if we do have that data and we want to evaluate AI, do we even know what success looks like? What we would call sort of the evidence standard in healthcare. And then finally, even if these computational tools achieve the types of output that we want, can we give them to people in the right time, place, and format so they become actionable? And I tell my students every day, you could have the most elegant algorithmic solution to a problem, but if people can't use it in the real world, it's still a failure. So let's start about picking the right task. So I'm going to give you a concrete example of that. Many of you are familiar with the opioid crisis. And one of the challenges that has faced us in healthcare delivery is how do we make smarter decisions around prescribing opioids in the hospital? And how do we detect adverse events when people receive these very powerful drugs? The state of the art is to look at FDA package inserts, which basically tells us what has been discovered during clinical trials with the drug. But we've actually shown through research at WashU and BJC that you can mine electronic health records and find unanticipated adverse events that happen when patients are prescribed opioids and other medications at the same time that include things like pulmonary embolisms or various cardiovascular complications. These are not in the FDA package inserts. They are not in the clinical trials data. This is real-world data or signals that have been extracted from the electronic health record. And if we can find these signals, it means that we can act on them and improve quality and safety of care. So, as a function of finding the right task, this type of preparatory research tells us that there is a signal, that there is data, and that there is an opportunity to automate the discovery of these types of potential adverse events based upon data that's already at our fingertips. So this is an example of a problem, finding unanticipated adverse events that function as a sort of co-occurrence with opioid prescriptions that we can act on. So this is a data-driven approach to find a problem that we believe is correct to pursue with an AI intervention. Now, let's say that we find a signal like that. Do we have sufficient data? Not just does the data exist, but is it sufficient to train the model? Back to my crash course on the development of artificial intelligence. So this is another example. This actually is a project focusing on sepsis. You've probably heard people in healthcare talk about sepsis. It's one of our favorite topics when we talk about clinical decision support because, unfortunately, it is one of our highest mortality conditions in the hospital, sometimes in excess of 30%. And the problem is, we usually detect sepsis when it is too late to intervene, and therefore patients end up in the ICU and critically ill. So, one of the questions we have asked on a regular basis is, can we find those patients in the hospital before they become septic so that we perhaps can intervene before they end up going to the ICU and becoming critically ill? Now, there is a myriad of mortality risk prediction tools using AI that have been developed, frankly, over the last several decades. And all of these have shown great results in clinical trials. But they all exhibit the same fundamental problem. They're based on studies using retrospective data that's largely administrative that doesn't exist during the patient encounter. So they work after the patient's been discharged from the hospital or become septic, but they can't be used during the inpatient stay to trigger an alert. So this was actually a study where we took every single one of those published risk prediction tools and we ran them against the raw, incomplete, messy data that's in the electronic health record. And what we learned is none of them worked at a level that would support clinical decision making. So this is an example of sort of the counterpoint to my prior example. The data doesn't exist in the electronic health record to leverage any of these well-published, well-validated, AI-based risk prediction tools to find those patients who are going to become septic. So back to my 4 critical questions in this second question, if we were going to use any of these tools today, the answer would be no. We don't, in fact, have the data to build meaningful AI that will improve care outcomes for patients and predict sepsis. But now let's imagine that we had a different case and we did have the right data. And now we want to find out if the tool works at a level that makes it worthwhile to deploy. So I'm going to shift and focus on a more rare disease condition. This is a rare genetic disease called neurofibromatosis type 1. This is the most common of genetic conditions that are diagnosed in newborns. It has a relatively easy pathway to diagnosis, but then the outcomes for these patients are highly variable and difficult to predict. Some children will have no symptoms. Some children will develop what are called plexiform neurofibromas, painful nerve sheath tumors. Some will develop optic pathway gliomas and lose their sight. Some of them will develop ADHD or attention deficit disorder or autism type burden. We don't know when we see a child with NF1 which one or which combination of these outcomes they will have today. So we can diagnose children and then we subject them to an incredible amount of ongoing testing and management in the hopes that we will identify these outcomes early so that we can intervene. In this case, we have a huge amount of data for these patients, and we've actually been able to show, using artificial intelligence, that sometimes with greater than 80% accuracy, we can predict at diagnosis which children will develop those outcomes: ADHD, plexiform neurofibromas, optic pathway gliomas. And therefore, we can tailor their treatment and management so we can intervene early and often and hopefully stop that disease progression, or at least manage it better. So this is an example where using expert curated data, clinical trial data, and artificial intelligence, we can in fact set an evidence standard that shows that this AI tool is better than current clinical decision making and will improve quality, safety, and outcomes for children with NF1. But then finally, even if we have the right task, we have the right data, we have the right evidence standard, we still, as I said earlier, have to bring that back to the point of care or to patients or the individual who's going to act upon those recommendations that AI is going to make. And I'm going to shift gears and talk about providers as opposed to patients as the focus in this issue. So it was already mentioned earlier that we have huge amounts of burnout in healthcare. And one of the things that we know unequivocally is that providers experiencing burnout also make mistakes more often. So one of the things that we've actually done is found that by mining the log files that show how our providers interact with the electronic health record, we can actually identify those individuals who are experiencing burnout because there are certain patterns of interaction with the electronic health record that correlate with standard psychological measures of burnout. And further, we can anticipate whether or not they're going to make medical errors. So we can use AI to mine the electronic health records log files and anticipate if someone is going to make a mistake and then intervene and prevent that mistake. And we've already shown that we can do this on wrong medication errors. So when someone places an order and the medication may have an interaction with another medication that the patient is receiving, we can actually anticipate that and make that change at the time the provider enters it into the electronic health record by recognizing that they may be engaging in workflow that is suboptimal because they are burned out. This is the use of AI at the point of care, improving workflow in the electronic health record with direct impact on patients. And this is about understanding workflow, because to arrive at this, we've had to do excruciatingly detailed workflow analyses to understand how our providers interact with the electronic health record, how that correlates with their burnout status and clinical decision making. This is not a technical problem, this is a human factors problem. Do you understand how humans and computers work together in these complex, information-intensive environments, and then how do you intervene? So I want to wrap up and sort of bring it back to the topic today, which is, where do we in St. Louis and in the Midwest stand in terms of this evolving AI and healthcare ecosystem? Because I hope I've made the case to you that there is an incredible number of problems that we can tackle that would improve quality, safety, outcomes, and value of healthcare delivery using AI, as long as we answer those 4 critical questions. So that leads us to, why us? Why would we do that here as opposed to, say, on the coasts where everyone believes sort of the center of the universe lives when it comes to artificial intelligence? And by the way, just so everyone knows, I'm a native Southern Californian that went to school in New York. So, I am uniquely qualified to criticize the coast and advocate for St. Louis. Okay, so the first thing I want to point out, and it was mentioned earlier that startups are struggling with venture capital investment. And that is certainly a case. I'm on the board of a couple startups. I work with some of our local venture capital firms. But I want to be very clear that even with those constraints, we still have an incredible amount of startup activity and early stage investment happening in the Midwest. In fact, one of the first billion-dollar exits of a healthcare IT firm in the Midwest happened in Columbus with Cover My Meds, which was funded by Drive Capital. By the way, Drive Capital focuses on these types of investments in the Midwest. So we have an incredible volume of investment happening every day, even if it is slightly depressed due to the current status of the venture marketplace. And one of the things I want to point out about that, it is faster and more cost-effective to make those investments in the Midwest and build companies here than it is to build them in the peninsula or in New York or Boston or any other places we think of as a hub. And I've started companies. I can assure you that that is the case. So we have the workforce because of our universities, we have the investment capital, and we have the platforms in which to evaluate these technologies. So we need to embrace that. And actually, I'm going to talk more about healthcare expenditures in a moment in the regions, but I think this sort of comes together quite nicely. The second factor is, and it wasn't in the report, but I'm going to make a plug for our major universities, and I now feel very uncomfortable with the chancellor of the community college sitting in the room that I didn't include their logo on this. I should have, so I apologize for that. We'll say it was because there wasn't enough room. But nonetheless, if you are not familiar with the economic halo effect of major research-intensive universities and teaching-intensive universities, when we bring in $1 for research in a university, we spend $3 to $4 in the local economy. So I would challenge anyone here to find a multiplier better than that for investment. So Washington University, in our School of Medicine's example, we are the #2 NIH-funded medical school in the country. The only medical school with more federal research funding than us is UCSF, and we're getting very close. I'm a competitive person. I believe we can close that gap. So that is $800 million in NIH dollars going into the medical school with a 3 to 4 to 1 multiplier. Not to mention new technology that can be licensed and a workforce that knows how that technology works. Our universities are economic engines for new company formation, new technology generation, and innovation in areas including healthcare. And we happen to have more than one of them in our city, which is a unique advantage, and I think something that we need to lean into. So when you look at what's going on at Washington University, when you look at SLU, when you look at UMSL, when you look at the workforce that our community colleges are generating, we have incredible capital in terms of expertise, technology, and people to invest alongside that venture capital that I talked about a moment ago. And then finally, people think of cities like Cleveland or Boston as sort of the gravitational, again, center of the universe for healthcare expenditures, right? Because of Cleveland Clinic or Harvard. We have more healthcare expenditures here in the St. Louis metro region than either Cleveland or Boston. We are a hotbed of healthcare delivery and innovation, and we need to own that. And we have groups like BioSTL that's convened a healthcare innovation sort of entity that includes not only the sort of companies and organizations you see represented here in the state of Missouri, but also partners from across the Midwest that want to be part of that innovation ecosystem. That's happening right now in St. Louis. And importantly, if you don't sort of regularly live in this space, these are organizations that are regularly competitors, but we come together in the innovation space to share knowledge, expertise, and to design joint programs. This is a unique competitive advantage. We spend more on healthcare and healthcare services. We have top-tier organizations and universities. We have venture capital, and people are coming to learn from us. And I'm going to argue, back to my comment earlier, as a native Southern Californian who went to New York for graduate school, that one of our biggest problems is we don't promote ourselves enough in this regard. We are too nice as Midwesterners when it comes to sort of telling our story, and we need to start telling that story because this is the test bed for the AI revolution that I'm talking about. People do not receive the bulk of their health care in tertiary academic care centers like UCSF or Stanford or Hopkins or Harvard. They receive their health care in community and rural and safety net sites. That is where the bulk of the population receives health care. So if we can't innovate and deliver AI in those environments, the population will not benefit from it. Therefore, with the test bed that we have that includes rural, urban, safety net, underserved sites, universities, venture capital, all of that in one place, and perhaps a little Midwestern collegiality to go along with that, this is the test bed for the AI revolution that I'm talking about. And I think you already see this with some of the recent announcements from the county. I feel like we are just sort of starting to get the idea that we can position ourselves as this innovation hub, and we need to own that message and be leaders in the AI space. And I say this every day in every venue I go to, we do not need to be followers. We can be in front in the AI revolution because of all of the reasons that I've outlined today. So with that, I will just say thank you for your time and attention. I'll be around at the end to answer questions, and I will turn it back over to our host.
Okay, I'd like to invite up our panel. Dr. Pittman will be our moderator, and we have 4 panelists and a great conversation to be had around workforce and also thinking about healthcare as a barrier for our employees. How do we make sure we have the healthiest population that we can? While everyone's getting settled, a reminder as you exit today, pick up your business journal wrap. We also have some cards that have the QR code on it for downloading the report if you'd like to do that. And I will turn things over to Dr. Pittman. Here we go.
All right, test. Okay. Here we go for our panel discussion. And I first thank you, Dr. Payne, for a great presentation. And yes, we're terrific partners with Washington University. And you may not know this, but your previous chancellor, Mark Wrighton, chaired our campaign for the tax levy increase that we received in 2021. So I always loved what he would say to me. He goes, well, for every brain surgeon we produce, we need like 1,000 nurses. And St. Louis Community College, our focus is certainly on workforce and what we do here, but that was an impressive presentation that shows the power of what St. Louis and St. Louis region can do. So we really appreciate you being here today. Oh, we would love it if you added our logo. You added our logo. Okay, terrific. Okay, well, we have a distinguished panel here with us today, and I appreciate their time being here with us. And I've worked with some of these folks quite a bit in the past, so it's good to see them again. And I want to start out by introducing them all to you, and I'll first call your name and where you work. If you could tell us a little bit about your role in healthcare and a little bit about your organizations. And I'll start with Jill. Jill Williams is with the Missouri Hospital Association. So Jill, tell us a little bit about your place.
Yes, thank you, Dr. Pittman. I'm the Vice President of Workforce Development at Missouri Hospital Association. And my role at the association is I primarily work with our human resources professionals across the hospitals in the state of Missouri. So not only working with our HR professionals, but also with workforce stakeholders across the state, whether it be with our community colleges or universities, our schools of nursing and allied health, the Missouri Chamber of Commerce, the Missouri Department of Elementary and Secondary Education, and our Missouri Workforce Boards, as well as other stakeholders and organizations, trying to bring stakeholders really together to facilitate collaboration around the supply and demand of the healthcare workforce.
Okay. Thank you, Jill. Next, Dr. Catina O'Leary with Health Literacy Media.
Good morning. I'm Catina O'Leary at Health Literacy Media, and I'm the CEO there, the president and CEO. And at Health Literacy Media, we focus on providing health information and resources that are accessible to community populations. Our job is to help our stakeholders communicate with folks who are their audiences, their intended audiences, in language that is accessible. And we do that in written communications, handouts, materials, brochures, fact sheets, all of those things. Video. We want to make sure that people can read the written information, but also see that and have voiceover, all kinds of accessibility issues addressed with video and other information, websites, trainings for employers, as well as employees and community members in other places. And we want to make sure that that health literacy gap is managed. And this is particularly important when we start to think about workforce training and development, because if folks don't know how to process the information they're getting, that's a real problem. But if healthcare professionals can't help them process it and give them the correct information, it doesn't even matter. If they get the wrong stuff to begin with, we're going nowhere.
Thank you, Catina. Danish, welcome back. Dr. Danish Nagda with Rezilient Health.
Yeah, hi, my name is Danish. I'm the founder and CEO of Rezilient Health. We help employers reduce healthcare costs by providing same-day access to care. So one of the biggest challenges that employers are facing in the area is it takes 3 to 6 months to get an appointment. It is quite hard to get access to a good doctor nowadays. And what we do is we bring the world's best doctors to St. Louis, but they're on the screen in the clinic. And all the tools in a clinic are connected and live streaming to the doctor remotely. And not only can you get access to primary care, but same-day access to 73 specialties. No more waiting 3 to 6 months for healthcare. And we started a couple of years ago, and today we serve 25,000 patients.
That's terrific. Okay, next we have Adwele Jolly with St. Louis Integrated Health Network.
Good morning. Thank you for having me. I serve as the president and CEO of the St. Louis Integrated Health Network, which is a healthcare intermediary here in the city and county, comprised of the largest health systems that you saw on the screen, the federally qualified health centers, the health departments, and the medical schools, and one community-based organization working across sectors to increase access to healthcare and improve well-being in our communities, especially those that have been historically excluded from opportunity. We work to co-create ideas and solutions to ensure that the voices of the unheard and those who are at the margins of our society, who have been marginalized, get access to health care. And we want to make sure that your health access, experience, and outcome is not predicted by your background. And we want to make sure everyone has an equal opportunity to live well in our community.
All right, thank you. Before I get started here, so I'll start with some questions, and I'll probably prompt one or two of you to respond. But I would like this to be as conversational as possible, so if the others would like to join in a response, please do so. But I'll lay a little backdrop, and Phyllis has covered some of this from the report, but we all know that healthcare is a really important part of St. Louis. And research and patient care serve the much larger region around us as well. It expands beyond our boundaries. And you've already seen the incredible data point of 221,000 healthcare workers in the region. And a big part of what we're doing at St. Louis Community College is a lot of the new buildings going up are in healthcare. And we're all said and done, we'll have 3 new healthcare buildings because we understand the significance of that. Over the last 10 years, we've seen employment in healthcare grow by 14%, again, making it the largest sector. And healthcare was heavily stressed during the pandemic. I think we all lived through that and can feel that. And the workforce has struggled with burnout and high rates of turnover. So not only do we have a lot of vacancy rates to begin with, we have people getting worn out from the fact they have to do work a lot of extra hours to cover for that. So Jill, I'll start with you on this question. As we move past the pandemic, what are the biggest healthcare hiring challenges that you see in the region?
Thank you, Dr. Pittman. I made some notes because if you can imagine, I'm pretty passionate about this topic and wanted to make sure I stay on track. But yes, there is a widespread talent shortage when it comes to our healthcare professionals. And I think there's several contributing factors, one of those being demographic shifts. So we have an aging population that is requiring more healthcare. We also have an aging workforce who are nearing retirement from our healthcare organizations. When you combine that with declining birth rates, a tight labor market, there's just going to be more work to be done with fewer people. We're also seeing a shift in work-life balance. So individuals are requiring more work-life balance, and that's really requiring hospitals to reevaluate their options for flexibility, their work environment, and the benefits they offer to staff to help recruit staff into the hospitals. Also, as you mentioned, the burnout and mental health. Careers in healthcare can be emotionally taxing with high stress and high demands. So again, that can be a deterrent for potential applicants. And then when I think about education and training, many of our roles in healthcare require some sort of degree or certification. And there can be barriers for those potential students. Earlier it was talked about childcare and transportation. Whether it's financial, personal, or otherwise, those can be limiting factors for individuals to access the education that they needed in order to obtain a career in healthcare. And that's why it's really important, as Phyllis mentioned, that we offer those Earn While You Learn programs, tuition reimbursement, scholarship, and those types of programs to support our students through their journey as they're training to be future healthcare professionals. And then the last thing I wanted to mention is kind of that lack of awareness. So many students and young adults are familiar with doctors and nurses, but aren't really familiar with the careers beyond that. And many of our most in-demand careers are in that low and middle skilled jobs. So they require less training than a doctor or nurse, and they can really lead to stable salaries with stable lifelong careers.
Okay. Yes, Wally.
I was going to add to that in terms of the aging workforce, not only those who are entering the workforce, those who are in the workforce are aging out, but also those who are the educators. And so in the state of Missouri, one of the reports showed that 100 nurses are retiring and nursing educators are retiring this year. And I think also that as a physical therapist, we're seeing that in the same way. But in terms of balance around competition, we're not only competing against healthcare organizations, we're competing against other types of employment. I just recently lost an employee who's going to go be a nail tech. And so know that the competitive landscape goes beyond healthcare. And as an intermediary, we sit between not just hospitals, we also center community health centers. And even within that space, about 68% of community health centers said within the last 6 months, they're gonna lose a quarter of their workforce. And about 15% of them will lose up to half of the workforce. And then of those who are leaving the community health center side, who are in the front lines of serving the safety net, a majority of them say they're leaving, not majority, 25% of them say they're leaving for higher wages at other healthcare organizations. And so as an intermediary, we sit between all those different partners to say, we need workforce both at the hospital level, but also at the community level. And how do we balance that in a market where it's much more competitive and goes beyond healthcare for the workforce?
Just wanted to mention one part. I'm gonna say something that I think we all know, but doctors are not okay. I don't know if you've heard this. If you know doctors, they're not okay right now. The pandemic has been taxing. I think the loss of trust between the doctors and patients has been quite difficult for doctors to deal with. Last year, 117,000 doctors quit. If you look at the data, there's only 1 million in America. Doctors are not okay, and it's something that we're not talking about, because what's happening is we are in a sick care system. And the sick care system means that you have, as a doctor, I'm a doctor myself, you as a doctor have to focus on the sick patient instead of preventing somebody from getting there. Cancer rates in young people are the highest they have been. I'm sure a lot of people read the New York Times article on it a couple of weeks ago. People are not getting colonoscopies, they're not getting mammograms. You get 4 minutes with your doctor. It is out of control for young people. And so it's not surprising that young people are not okay either, right? And when I say young people, I mean less than 65. That's young. Hey, give yourself a pat. That's young, right? Because ultimately, what's happening is that the large majority of doctors are being forced to, and there's this moral injury that comes from it, which is giving you 4 minutes because they've got a very complicated patient right after you. Of course, it's triaging. You've got to do it. We've got to take care of the patients that are in front of us. But you know what's happening? We're not talking about colonoscopies. We're not talking about mammograms. We're not talking about losing weight and stopping smoking. We're not doing the things that doctors used to do when I first started. It's changing very dramatically. And I think as we see the workforce shrink, this problem is about to get much, much worse. And I wanted to warn that, because if you go to your doctor, think about the fact that how often does your doctor actually look you in the eye instead of looking at the computer? I agree with the EMR commentary, but the EMR has gotten in the way between the doctor and the patient, right? I mean, we all feel it. So I'm just saying the quiet parts out loud that doctors are not okay. And I think that there is a huge wave of opportunity coming with AI, but something that we know is doctors that are gonna use AI are gonna be better than doctors that don't use AI, right? But at the same time, we've got to make sure they're still doctors, because they're leaving at levels that we've never seen before.
I appreciate all your comments. And like Jill, I have a real passion for the healthcare workforce. Notice I missed the young person mark on the 65 and younger. So I have a vested interest in this healthcare business as well, but the aging, aging population, aging workforce, and the high burnout that you're talking about, things that I feel like, at least at our level at the college and the level of employees we're working to provide, we're investing as much as we can in this issue. And I think, the medical schools are going to be in the same boat, it sounds like. If you've got that kind of exodus, you certainly have to think about how can we encourage young people to get into this profession. All right, next question here. And Dr. Jolly and Dr. Nagda, I'll start with you here. The face of healthcare is changing, as we've been discussing here. Traditional models of care and insurance do not serve many in our community. What trends are you seeing in new models?
So, I can speak for our model. We don't charge for volume. That's a huge shift. I think Dr. Payne earlier was talking about value. Value in healthcare has to be redefined. Today we define it as quality over cost, which I think is good, but that's really a payer-centric approach to to healthcare because the average employee stays for 18 months. So really, if you don't cut the cost in 18 months, is that not valuable to that patient? Right? So we really have to have a deeper discussion around that. The way things are changing is there has been this like huge change to value-based care. And I think that the fee-for-service model reigns supreme, but its days are numbered because ultimately, who is paying for it? Well, 40% of Americans get their healthcare through their employer. So if you're an employer and you pay per visit and the visits are getting shorter and the quality is getting worse, are you just gonna keep paying? Or are you gonna go out there and find new models? And the new models that are rising are subscription-based models, risk-based models, value-based models, where the providers say, you know what? You have hired me to take care of your people. It's now my job to actually take care of your people. And I'm willing to put my money where my mouth is. And I think that that is what's coming, and it's coming at a level that, you hear about certain companies that are growing, but there's a reason why a company like ours, right, a startup, comes out and in 2 years grows from 0 customers to 300 plus now. I still get the numbers wrong. And it's because we are aligning ourselves with the actual person that's paying for it, which is usually the patient and their employer. And I think that that's what's changing, at least on the commercial side of the business. And I'm sure there's a lot of other new value-based care models. Luckily, Medicare actually led the way, not to point at you, but Medicare led the way, with Medicare Advantage. And so, what it's done is it's set up the base to say, hey, healthcare system, hey, provider of healthcare, there is a way for us to be aligned. Can we become more aligned so that you're not just making more money the sicker our patients get? Because that's actually how healthcare works today. That's why I left healthcare. And
Me too.
Exactly.
Yeah, I mean,
No, I'm done.
yeah, no, I mean, I'm a physical therapist by training, as I mentioned previously, and seeing the mixed incentives, the moral injury, the moral hazards that come with like how you get paid and reimbursed and the quality of care you're trained to do. So it's no wonder you have a workforce coming out of grad school wanting to do the right thing, but then get hit with the storm of mixed incentives of what is valued by the employer and by the payers. One of the things I see in the trends, as mentioned on the slide, 59% of the time, employers are forced, as saw on the slide, to hire people who are less experienced and less trained, while offering wages 45% higher than they would, right? That was on the slide. And we're now moving into more gig employment models where employers are trying to make it flexible for the workers to identify when and how they would like to engage in the workforce, rather than relying on external staffing agencies. But understand what we're saying, how you were likely trained in the same way. Consistency was a big part of skill development and the care we render to our patients. And so the question is, as employers are trying to adapt to the new workforce environment, how are we providing training consistently and in a deep way for a workforce that's coming in that needs to be, and they want to. I don't think it's a desire of not wanting to have strong skills, deepened skills, and more experience in the work they're doing. But if I'm constantly just picking shifts, I'm not in the same environment, with the same sort of apprenticeship model to have a deeper way of providing care, we're going to see what you've experienced or just talked about. How do we achieve a value, both for the workforce and for the patients who are depending on that employee to have the skill, the level of knowledge to render care on a consistent basis? So that's one trend I'm seeing is the gig employment model. Everybody is its own entrepreneur, and how do we manage both the needs of the employer and the patients?
I would just add, as a small nonprofit CEO, for the last 3 years, every year when I get my updated insurance information, I've had enormous increases. So I have 34 employees. This year I got a 35% increase in my insurance. For the last 3 years for these 34 employees, and it's gone from 25 to 34. So I've had increases that have looked like that. So we've been bumping from plan to plan to try to keep our costs low. So that means every year our employees are changing plans. So I've got 34 people that are in a nonprofit focused on health literacy, and they got to this job because you come to these jobs because you care. There's a reason that you joined this group. You joined a nonprofit. I work with some of the brightest people in the world. They're the best writers I've ever seen. They can make things so clear, so easy to understand. I mean, they're medicinal chemists, they're biologists. They are brilliant, brilliant people that could go work anywhere and make 4 or 5 times the money. But they came here for a reason. So they're sitting in my office changing their insurance every year. And they don't have great insurance right now. They're paying a lot of money for it. They don't have great coverage, and it changes all the time. And when I ask them every year, what do you want to do? And they say, I want to stay as close as we can to the plan we have because I like my doctors. And across the group, we have people with health conditions that it is flat out scary to move between mental health and chronic disease and all the things that are happening with people, because the rest of us aren't okay either. It's not just the doctors that aren't okay. All of us are not okay. Our employment has been up and down. We've been worried about how we're going to pay bills. All of the other systems that are paying us to stay in business so that we can write those clear health information pieces for people to get the information they need because their doctors don't have time to explain. They don't want to pay us for it, right? So we're like struggling to find ways to do it for free, and these folks can't do it. And then we go to the doctor, and they say, geez, like, you've got this problem. I've heard this from 2 or 3 people in my group in the last 2 years. You've got this problem. We see on the mammogram all these things. You need to go get an MRI because we don't know what's going to happen. But guess what? We're not going to pay for it because we're not really sure you need it. We're just going to wait until you get breast cancer. We're just going to wait, and we're going to figure it out. So when we think about how people feel at work and what we're doing and why they're making the choices they make, they're also burned out, and they're overwhelmed, and they're frustrated, and they're not coming from a good place. And when we don't have choices around benefits, that's a problem. And when we're not able to offer them anything, so I can't pay them what some of these big companies can pay them. The only thing I have is a good place for them to work where they feel good about themselves, and I can give them decent benefits, and that rug's being pulled out from under me. So when we think about workforce, that's one of the other things we need to think about is how do the various industries compete when the resources are constantly being pulled in all these directions? That's a problem.
Okay, well, this next question is for all of you, and maybe you've answered it already. But, we've heard a lot about the workforce problems that you're all experiencing or seeing because of burnout or not enough workers that are in place. But is there another issue? From each of your perspectives, what's the largest issue facing healthcare right now?
It's interesting to listen to the talk on AI. I love that. I went to a conference a couple years ago, and I love the frame here that AI is not going to replace humans, that humans in the loop are mission critical. Because I was in a drug pharmaceutical conference, and there were folks from all the major tech companies, so Microsoft and Meta and blah, blah, blah. And they stood up in front of the room with folks from pharmaceutical companies and said, like it or not, we've all invested big in AI, and we're going to take your jobs. We're going to take your jobs. We're going to take the parts you don't like, so it's okay. We're going to take the things you don't want to do, so it's okay. Don't worry about it. But when they started to talk about the things we didn't want to do, they were all the things that were involved with people. So everything involved with people is what we don't want to do. So we're writers. So they were going to write all the materials, and they're going to do all the images, and they're going to do the work that graphic designers do. And they're going to do all that so that we can write the reports that they've drafted and make sure that we proofread for errors. So I raised my hand because I'm nosy and I've got big opinions about things. And I said, well, how do you validate these models, right? I'm a behavioral scientist. So I said, you got all this data and you pulled it from all these places. So how do you validate it? Because I do a lot of audience testing and user testing for things. And they said, what do you mean? And I said, well, how do you validate them? How do you know that what you put in the model is right? And they said, well, we have so many models and they're so big, we don't need to validate them. They validate themselves. And I said, well, I understand that at some point, maybe that's a little bit true, but I also understand that a lot of people aren't included in your models. I understand that there are big groups of people, communities of color, people from other parts of the country, or other parts of the world. There are people that have been systematically excluded. There are people with rare disease that haven't even had the opportunity to be surveyed. We don't even know what those things are. They've never been included. So how would we know about them when they've never existed? How do you validate that? And they patted me on the shoulder and they said, well, you don't really understand. You don't really get it. You know, I felt the like little girl thing. So there's this thing that we can't have a conversation because those people in that community have invested so much money. They've already decided, we've got the hype. They're going to push it through as quickly as they can. And there are groups of people that are, you know, chasing this shiny, you know, penny. They're going to run as fast as they can against the shiny thing. And they think the rest of us are scared, not critical. So we can be critical thinkers and ask real questions, and that doesn't have anything to do with being afraid, right? And so we have all these people who are doing real work because we care. I want to test materials and I want to validate them because I don't want something to go out into the community for an audience that reminds them of historic mistreatment in the medical system. It only takes one of those to take people back to something that is so gut-wrenching and so horrible that we're back to that place that they remember their grandmother telling them about, and it's all over. We're back to square one. So I want to test the material to make sure that doesn't happen. I want to make sure the image doesn't remind them of something horrible. I want to make sure it doesn't flag something. I want to make sure the words when we translate are not wrong. That is really important, and a computer cannot do that. It cannot ask the questions, and it certainly can't ask it when the data weren't included in the first place, and they haven't been. So I think that's one of the biggest problems. It's scary.
I will say the other side of that, which is I think that there is an opportunity for AI to restore the humanity in medicine. Eric Topol wrote a book, very good book about this, and we're using it right now at our clinics today so that doctors can pay attention to patients instead of paperwork. Another, you know, again, Dr. Payne, not picking on you. Unfortunately, I also studied active learning, so it's unfortunately a background in academic research in that. I was going to say, ultimately, what's challenging in medicine right now is the electronic medical record is more of a billing record than it is a true medical record. Any doctor can tell you, any person in healthcare can tell you. So what you're doing is, and it's biased. I'll give you two simple examples. Most importantly, my co-founder, Jeff, PhD in neural engineering from WashU, focused on AI. And you know, his mother, a Black woman, went to a doctor for 5 straight years, her primary. They told her she had anxiety when she had heart failure. If you looked at the medical record for those 5 years, do you think it would say, I think this patient actually has heart failure, but I'm telling her it's anxiety? No. So the bias was coded in, right? So if we're going to use that medical record to come up with what is going on, it would say, this new Black woman probably has anxiety, right? So this is kind of what you're talking about. But I think that there is better data out there. I think that data is coming. It's imaging data. It is the data, you know, we've seen a rise in virtual care. And if we use some of that data to train things, so we can actually see what the doctor-patient interaction actually was, not what the doctor says it was in the medical record, we can use that to catch a doctor and say, you know, doc, I think you're biased. Which I think a lot of doctors would actually want to know. No one becomes a doctor, you know, in your essay from medical school, no one says, you know, I really want to treat Black people poorly. Like, nobody says that. People become doctors because they want to help people. People become physical therapists because they want to help people. The bias is from the system. We need to fix the system. And I think that's what's super exciting, is that AI can bring the humanity back, help find, because there are doctors out there today that are not using AI that are incredibly biased. I work with some of them.
Can I respond really quickly?
Yeah, go ahead.
I don't disagree one little bit. I think it's a use case issue. And I think people who are building it think everything's a use case. And I think it's our job to identify the use cases. And what you're saying is a phenomenal use case. Writing materials without testing them, not so much. So we have to figure out how to use our brains and make good sense about what works. And that's where we're not right now.
And I think that's what Dr. Payne was advocating for.
And
I think that's what he was
dangerous.
advocating for, is that our job is to figure out to ask the right questions. So active learning is when you ask the right question. So it's literally semi-supervised learning where we talk about what's the next best question? Isn't that the thing that we should be really talking about with AI? What's the next best thing we can do? So I'll give you a simple example. Our doctors don't document anymore. It automatically documents for them. Wouldn't you wish your doctor did that so they could actually talk to you instead of turning around and looking at their computer, right? And so these are the things that we believe AI will augment so that you can restore the humanity in medicine. On the workforce side, I wanted to say one thing, which is there are a lot of problems with workforce, but there's a ton of opportunities. One of the biggest opportunities is community-based care, where we can get communities that have been left out of the healthcare workforce, bring them in, give them incredible apprenticeships, and use technology to make them 10x better than what we have today, because they understand the needs of that population. My father came to this country, he was an immigrant, didn't speak English well, which, his doctor would come in and he would say, "Hey, Mohammed, how you doing?" He'd be like, "Oh, I'm great," because that was one of the 10 words he knows how to say, right? If people know immigrants as well, I guess. And so, but he had sleep apnea and ended up having a heart attack at 53, got heart failure at 60, and as a surgeon, I was going home after a long shift and taking care of my dad for nearly 10 years, which is why I left, and the moral injury that came from the fact that they missed it. If there was a community person there, they would say, "He doesn't know how to speak English." Let me get a translator here. Like we, in the community that we lived in near Chicago, most people don't speak English that well, right? And so, again, not to hate on doctors, that is not the goal. I am one, right? So the problem is the system, and there's a huge workforce opportunity. I've been talking to Phyllis about, for example, we use paramedics from the community as our front line. Those paramedics, they understand the problems of that community. And we can upskill them by providing them with apprenticeships, great programs like at the community college, where we can train alongside the community college, so they have the skills to be the hands of the doctors remotely. That is something that is incredibly exciting. So I know you asked what's bad. We've been talking a lot about what's bad. I think what's exciting is that we're gonna start seeing a lot of innovation in workforce. And I think that's what we can't, our city is very well set up to be the innovation hub for healthcare. Not only because we have the highest spend, I think that's not always a good thing. I think it's because we have great people, and a lot of them are leaving the big systems and they're building. And I think the building is the fun part. And so, I would encourage people to be more positive about that, because we have a huge opportunity here in St. Louis.
I can
Any other-
speak to concerns, some of my concerns and opportunities, I guess, coming out of the pandemic. It's definitely, several of us have hit on the mental health, the burnout and exhaustion of our healthcare workforce. Again, just the need for healthcare organizations to really support staff and reduce that stigma around seeking help, which tends to be extremely hard for healthcare professionals, especially to do. When it comes to opportunities around workforce, back to our conversation around AI, so we know that healthcare organizations have to be staffed 24/7. And again, kind of comparing with that work-life balance that individuals are now seeking more than they were pre-pandemic, I think there's an opportunity to use AI in those workforce situations. We see several hospitals here in the St. Louis region using predictive analytics. They are using app-based scheduling models where staff can go on and schedule when they want to work, how they want to work, where they want to work in that gig-based environment. So there's definitely opportunities there. I also think, when it comes to bedside care, there's more of a focus on bedside care and using AI in clinical practice to maybe automate and again, predict high levels of patient flow, low levels of patient flow, so hospitals can staff accordingly and use resources more efficiently, as well as just using AI in several ways to take away those administrative burden. So those who work at the bedside can spend more time at the bedside, because that's really where healthcare workers find their joy. And we want to bring that joy back to them and take away the administrative burdens. And we can do some of that with AI.
And, wonderful. And my IT boss from college is here, and he knows I know nothing about computers. So I won't comment on AI. But one of the challenges that I've seen is that presented actually by Phyllis at another meeting, where we're looking at the number of high school graduates in the state of Missouri. We peaked last year, and by 2027, I think it will be the lowest it will be in over a decade, which means that in about three years, we won't have as much workforce as we had yesterday. Understand that. And Dr. Hubble and I also spoke about, well, who's left out? We talk about the racial inequities within health systems, but also in the educational system, in the educational attainment system. And if we're not focusing, so our problem is our opportunity is young Black males are underrepresented by huge numbers in our health professions. And so if we want to have a chance at maintaining the growth of healthcare, the demand for healthcare, and the demand for workforce, we need to center young Black boys. Yes, we need and one of our strategies at IHN with the Safety Net Workforce, we're hoping to build a health academy in partnership with you all, everyone in the room. Think about how do we provide insights, gain interest, and inspire young Black youth into health professions so that we have the opportunity for all of us to be well in the St. Louis area. And so we call that a targeted universalism approach, which means by centering those who are most marginalized, we all benefit. And so if we can get our heads around that by centering young Black boys, we all benefit, I think we have a shot at improving our workforce demand in the future.
All right, thank you. So one final question, and it kind of is a culmination of a lot of your comments, because it's coming down to access to healthcare. And so for our audience here, of our civic, government, and business community, what one thing do you wish would make healthcare more accessible to the St. Louis workforce? Tina, do you want to start with you?
Not really, but I will.
Yeah.
So I think accessibility to the workforce is, not my area at all. So I'm actually going to defer this because I don't have anything to say about it that's useful.
I'll talk to just kind of my version of that is thinking about health equity and social determinants of health. And I'm excited to see how hospitals and healthcare organizations in the now and in the future will continue to partner more together to address those social determinants of health and those inequities. And to me, I also think, because I'm in workforce, what is also that connection of those groups into the workforce? We have great jobs in healthcare, and you can get them you can come in a very entry-level role, skill up, and advance your career. So how does that interplay in that as well? So that's just something that kind of comes to mind, looking through a workforce lens, but then also as an employer, offering affordable insurance, on-site screenings and visits and vaccinations and things. So employees who don't have that transportation or can't take off to go to an appointment can at least get some of that preventative procedures done on-site or as close to on-site as possible.
I think one of the things that was presented earlier around employers' mind shift is supporting their employees who are coming in at entry level, providing them opportunities to train with wraparound services and support to allow them to upskill or train into a higher level if they choose profession. So I think some of those strategies are starting to happen from an access and equity perspective, recognizing that not everybody's going to go through a four-year program, but may arrive at a PT degree at some point in their career with stackable credentials, opportunities for exposure, and support from the employer base and community around their needs, whether it's transportation, housing, and some of those other factors, childcare, that limit their ability to access the workforce.
I think this problem, I keep using the word system because I think the system is broken. And I think we have to replace that system with a unbroken system. And I think to do that, we need to build an ecosystem. And when I think about one of the big challenges for St. Louis and what's happened is that, before the 70s, I like history. Actually, a lot of surgeons do. I don't know if you guys know this, but it's like a weird part of our culture. Before the 70s, there used to be a belief in the St. Louis area that if you're going to hire somebody, you might as well hire somebody local. If you're going to work with somebody, you should work with somebody local. It used to be a thing here. Now, it's the opposite. It's a very interesting problem that has happened where I think because of issues with performance, people started going out and working with companies. So we were talking about startups, for example. When you're looking at a vendor for your company, how often do you take into account the fact whether they're headquartered here or not? Be honest, you don't have to answer it. The answer is probably not very often. When you're looking at a nonprofit to work with, how often are you wondering if that nonprofit is local? Of course, if you have an existing relationship, it's different, but do you actually take that into account? When you're thinking about hiring somebody, how often do you say, well, this person is local all the time, right? You say, oh, okay, they're local, it's gonna be easier. But how often are you willing to take somebody who's earlier in their career and say, they're local, we should support the ecosystem? Let me get them a little bit earlier, let's get them into the community college, help educate them and get them through. And I will tell you, another part of my father's background, my father passed, but another part of his background is that his employer did that. He went from being on the floor to becoming foreman. All 3 kids went to Ivy League schools. That is the ecosystem we're talking about. We're not doing enough of that right now. And it's a shame that all the employers aren't doing this. Because ultimately, we have to have a longer term vision. We shouldn't be thinking in I'm a startup guy. I'm supposed to be thinking in 2-3 years, right? We've taken a lot of venture investment, we're supposed to grow fast. But you all, as an ecosystem, should be thinking in a 5, 10, 15-year time frame. And that is not about trying to convince somebody from outside to come here and fix us and save us. That is not the answer. The answer has to be, well, let me invest in my community. And you know what's gonna end up happening? You'll have more workforce than you can ever imagine. Because there's a lot of great people in our community that just need a little push, maybe a little education here, a class there, and they are willing and excited to work, and they understand your customers because they're local. So if I was gonna leave with anything, I would say, I think it's time for us to invest in our local ecosystem. It's time. We can't wait anymore.
All right. Thank you, Danish. Can we give them all a round of applause? They just did a terrific job, and boy, I'm more inspired now in regards to the things we're doing at the community college to expand our workforce training and our program in these areas. And I think even the new buildings we're building, we're trying to make them, we use the word turbo, where students, young people can go in and see those opportunities through glass walls and see what the students are doing, see our simulation spaces and our clinical spaces. We're fortunate. I mean, we're really in a great place here in St. Louis, I think, to overcome some of these problems with the university partners that we have, with the other educational institutions we have. And again, just thank you so much for your taking the time out of your schedules and for all of your expertise. And I want to thank everyone who took the time to be here today. It's great to see you all. And Dr. Payne, thanks again for your presentation on AI. I think I know a little bit more about it before I got here this morning, so appreciate that. And certainly our partners who support us through this event, I want to thank them again. And all of the St. Louis Community College staff for putting this together and for the food that was provided. Thank you for that. And again, I want to do the little commercial here. Make sure you take the time to get on our website and download the full report at stlcc.edu/STL Workforce. And again, make sure you pick up the Business Journal wrap before you leave the building and look for upcoming information in the Business Journal about the event. But thank you so much for coming. I hope you have an enjoyable day. Enjoy the cooler temperatures. Thank you again.